Okay.
Are we starting?
Yeah.
Great. So,
1 second.
okay.
Good evening, everyone. Respected Dr. Ankit Solank, members of IATP and dear doctors. We welcome you back for another episode learned from our master series organized by IATP. And yes, crossing 50 webinars is definitely an amazing ride so far. And I thank all the doctors who are attending our webinars and other platforms like our Instagram and Facebook pages. We are very humbled to see your positive feedbacks. For those who are attending our webinars for the first time today, we will just give a brief introduction. We are the International Association for Dental Practice Excellence, a dental platform in which we believe quality education always ensure predictable outcomes of dentists of all disciplines and abilities. Our organization is established based on the fact that the dentistry is complex and requires ongoing learning experience. We conduct various webinars and workshops to enhance the skills of dental professionals and guide their dental journey. So, without further ado, let us start our series episode in which our topic of discussion is immediate implant placement given by Dr. Ankit Solanki. To speak a few about Dr. Completed his BDS from Naya Hospital Dental College, Mumbai in 2013 and has done his MDS from Government Dental College and Hospital, Nagpur in 2017. He had worked as an assistant professor at GDCH, Nagpur and is currently working as a head dentist at Holistic Dental Care, Mumbai from 2019 onwards. He is an educator with Right Global Mentor for Fellowship in Modern Implantology with Right Global Lecturer and Mentor with Integrate Implantology. Without wasting more time, I would like to invite Doctor for today's discussion.
Okay, thank you very much. Actually, I was also going to say something very similar. You have saved one of our slides now. And since we have very limited time, I'm directly going to jump to the presentation. Okay, let me just. Firstly, am I audible to everyone? And if
Yes,
not, you can just say. Otherwise, I'm just going to start. Mm,
yeah,
Give me 1 second. Yes, great. So, as I've already been introduced, that I am from this beautiful city of Mumbai, and this is where I live. I have done my graduation from Nair Dental, and this is my post-graduation college. This is where I currently work. This is my clinic, and I'm even a mentor for the fellowship in implantology with Ripe Global. So, firstly, most of us over here are either already an implantologist, or we are going to become implantologist, or we are just started our journey. And most of us generally start with some easy case like this, where we have lost one of our molars or some premolar area, and we try to replace it with an implant, right? We place our regular implant in such a case, and what do we generally end up having is some kind of bone deficiency. If we really want to cover it up, we might do some bone grafting and we close it up. And eventually, in few months, we would be giving some kind of prosthesis over it. And this is how it ends up looking. And a lot of us would be actually happy and just contented with the delayed implant placement because they are quite easy to do. Implant in general have become quite predictable. The success rate of implants is very high, right? Problem is that delayed implant have a very inherent tendency of giving an outcome which in many of the cases will not be 100%. And that arises from the fact that we are placing the implant and the starting point of delayed implant is not very ideal anatomy of the soft and hard tissue around the area where the tooth is going to be replaced. So what happens exactly is whenever we extract a tooth or we extract some teeth like this, At this given moment, we have beautiful anatomy around the extraction side, right? We have good buccal bone available. In most of the cases we do. We have very good soft tissue around it. And the moment the tooth is extracted, the question is, if we wait, what is going to happen? Like either we can go ahead place the immediate implant, or we can actually wait few months for for the site to heal. And inadvertently, what we'll be having is a healed site, but with a lot of loss of soft and hard tissue. And that makes a procedure a bit more easier. Like we do have a lot of bone in most of the cases still left for implant placement, but the outcome is not going to be as ideal as a natural tooth would be having around it, right? So the question more should be about how we should be placing immediate implants in a much more predictable fashion so as to maintain all of the soft and hard tissue, right? Like just imagine one of these cases, we have a root piece, and just the presence of this root piece keeps the soft and hard tissue around that site intact, okay? And as soon as we extract the tooth, we are going to lose all of it. So instead of extracting, if we are placing an immediate implant, what we can achieve over here is, as we can see, is a very wonderful maintenance of the surrounding supporting tissue, the emergence that we can obtain for the prosthesis, the maintenance of the keratinized tissue is far more superior than what is achievable in most of the cases with delayed implant placement, right? Like imagine this is the tooth. We have three options at any given chance point. We can either extract the tooth and do nothing, we wait for it and let it heal, or we do socket grafting, or we can do an immediate implant. So, whenever the tooth is extracted, what is going to happen is inadvertently we'll be losing a lot of bone. This is how the healing happens. We know it by a lot of studies, we know it by our personal experiences. The loss of the horizontal bone loss is almost inevitable, and it's very, very few cases where we'll still be left with good enough bone. Okay. So we will be losing a lot of hard and soft tissue, which is present if we extract and do nothing. So the other option is either to graft or to do immediate implant. So when do we do socket grafting? I feel only in cases where immediate implant is not possible. So even for me, many, many years, I have been doing delayed implants. But as soon as I realized what are the advantages the immediate implant can actually provide, I've been more focused. Like every single case starts with the question is, how do we place an immediate implant in this? Unless otherwise there is some contraindication to, okay, now this case is absolutely not possible to go ahead with immediate implant. That is when we think about either socket grafting or delayed implant. Okay. Now this is just a similar outcome what I've achieved by replacing a 3/6 in the two cases. One of it shows that one of this the left hand side images of that of a delayed implant and another one is of a immediate implant. Both the cases would almost be satisfied, but one of the most underreported problem with delayed implant is going to be the food lodgement. Okay, the papilla that we end up losing, a part of it might get recreated over a period of time, but there will never be 100% fill. There is always some gap left in between the sites whenever we are doing delayed implants. So what happens when we do immediate implant? We get better hard tissue stability. We have much more bone left on the buccal part. We don't need to regenerate because it was already there. All we have to do is the maintenance of hard tissue. We get better soft tissue stability. In what way? By maintaining the papilla. We also have already started with good amount of keratinized tissue. All we had to do is to maintain it. Okay. Overall treatment time obviously reduces because for most of the delayed cases, if we are extracting the tooth, either we wait for 6 to 8 weeks, which is the early implant placement protocol, or we probably wait for say 4 to 5 months or anything above 6 months. So as the site heals completely, fine. The patient acceptance is obviously going to be better because they are getting treatment done quicker. Okay. For them, it is not how we are doing it. It is how quickly are we doing it. So the patient acceptance is better. One more reason is there is obviously the higher chances of maintenance of natural emergence profile, but since we can temporize and give provisional, that is also one great benefit for the patient since we are doing immediate extraction, immediate placement of implant, and immediate temporization. Okay. So the question would be, why do we not often think about doing immediate implants, or why a lot of practitioners just stay for, and promote delayed implants, which even a lot of my seniors and colleagues have been saying, like, except for the anteriors, most of the posterior cases, people prefer to do it delayed. A lot of the reasons which we come across is that it is risky. Placement of immediate implants is risky. They have higher failure rates, or rather, it's a procedure which is not supported enough by the evidence. And to be honest, not a lot of educators and implant teachers are promoting the procedures. They are not actually saying how it is to be done, and it is the way to go. Since it's not being promoted by the people teaching it, probably that is the reason it's not uh, been done that often. The thing is, there have been a lot of meta-analysis reviews and studies related to immediate implants right back from 2008, 2011. We have Chokran reviews, and all of them state that the predictability is almost similar to that of a delayed implant. The question is still why people are not doing it. In my honest understanding, I feel that the immediate implant have a higher learning curve. Okay. It is not as simple as delayed implant. So whenever a lot of young dentists who enter into doing implantology might not have a great knowledge of implantology, okay? Because the procedure is rather more mechanical, even with limited understanding of biology and limited understanding of how implant works and how a particular implant system works. They can just get away if they are performing delayed implants, but that really doesn't work with immediate implants. Okay, it requires higher level of competence right from starting of how do we extract a tooth, and a, a in-depth understanding of the implant systems as to what implant system are you using, what implant systems are favorable, what aspects of implants are more favorable in what kind of conditions. Unless we have a real understanding of that, we are not going to be very successful with immediate implants. Okay. Understanding how osseointegration actually works, unless we know it, we would always be in doubt. Okay, if my implant is half into the bony site and half it is exposed, half of it is exposed, how is it going to actually integrate? What part is of it is going to integrate? Should I graft? Should I not graft? There are so many questions that are going to come. With delayed implants, probably if you don't know techniques of grafting, graft material, knowledge about graft material, you might just get get by sometimes. But that again doesn't work with immediate implants. Okay. And lastly, the overall cost of the treatment. Okay. Now, this is one of the factors where uh, uh, one of the excuses rather which I give myself, like if a patient is not able to afford XYZ kind of a treatment, or he's able to pay only a limited amount of money, then what do we do? Then maybe I'll be using a system which is slightly lesser in cost, and probably those systems are not very compatible with immediate implantology philosophy, and probably that is why I might go with delayed. Okay. But again, that's not the right way to really compare the two modalities because the outcomes are going to be very different. Okay. So basically, if we have the right learning and right understanding, there is absolutely nothing stopping us from doing immediate implant. So in whatever brief time today we have, what we'll be discussing is, hello, is someone saying something? Okay. Anyway, if someone is, please be on mute and I'll continue. Uh, so what we are going to discuss today is how do we make our immediate implants more predictable, and how do we successfully do it in maximum number of cases possible. Okay, so we'll be considering the two aspects which are most relevant to immediate implantology. One is the biologic aspect of immediate implants, and another is the implant consideration, the mechanical part as to what implant system and what exactly are we looking at when we are selecting an implant for a immediate extraction implant case, right? Both for anterior, posterior, any case as such. Okay. And okay, sorry. Uh, like the first step in doing any immediate implant, we start with a either a root stump or a fractured tooth or any tooth which is not salvageable. Okay. But the fact is the root is still inside the bone. There is a periodontium around it, and we still have tissues which are holding the root in the position. So the first step would be to conserve whatever is available. As we can see in this case, we have a premolar, okay, which is present over here. So if we are starting to remove the tooth, we cannot start with using blunt instrument like Moon's probe, or we cannot reflect the papillas. We cannot damage the soft tissue which is already there. The most atraumatic method of extraction would be first to dissect the periodontal ligament or the just separating the soft tissue attachment which is present till the alveolar bone, and then to very slowly luxate out the root. Now, it might not always be possible to take out root in a single piece. Probably in anterior teeth, we can rotate it and take them out, which is still a quite atraumatic way of extraction. But in posteriors, we need to section the roots. Like in premolar, since we have one buccal and one palatal root, I would be sectioning it mesiodistally. There are some cases where we need to section it buccopalatally, buccolingually, and in different ways. Once the root are sectioned, each of the roots are to be separately extracted, right? We extract one after the other so that we can conserve, preserve whatever the natural anatomy of that place is present at that particular time. And what we finally achieve out of it is a pristine, or we try to achieve in most of the cases, is an intact overall soft tissue around the extraction site to best possible way, right? Like again, in this molar case, we have two roots. One is the buccal and the distal. So what we are going to do is buc is a buccopalatal, buccolingual sectioning, so that we can section out the mesial and distal root one at a time, and we can preserve as much as the furcation bone we can for our implant treatment. What about in anteriors? So in anteriors, what I generally prefer to do would be to section the tooth somewhat like this from buccal to palatal so that my luxators would have forces on the interdental bone. But in some cases, we can actually avoid that by if we are planning the treatment in some other way. Like in this particular case, I sectioned it mm, mesiodistally rather than buccolingually. The reason being I'm not completely extracting the tooth. Uh, I'll be answering all the questions in the end. There'll be a lot of time, hopefully, because I'm not going to take the entire 1 hour. Okay, so I'll be answering it at that time. Uh, so we'll be sectioning the roots over here mesiodistally, and I took out the palatal root. And what we did is we modified the buccal root to create a buccal shell. So we'll be preserving the buccal shell, and then we'll be placing the implant. So there are a lot of ways in which we do atraumatic extraction. Understanding the right way, having the right instrument is the most fundamental thing for doing atraumatic extraction. Unless you have luxators and periotomes, it's not going to happen. Unless you use some kind of magnification, you can't really section roots, because once you section the root, and if this fractures, you'll be going still inside, and that's going to cause some kind of difficulties, because later on with the smaller root pieces inside, it's going to become more and more difficult. So some kind of magnification is also going to be required whenever you're doing atraumatic extraction, right? Second consideration, which is very important to uh, immediate implant, is the positioning. This is even important for delayed implant, or rather any implant, but specifically for delayed implant, immediate implant, what are the considerations that we are looking for? Because right now we don't have any specific anatomic structure. Like we don't have the crestal bone where we can say, ki, okay, this is my reference point and I'll be going 1 mm below my crestal bone. Since we are not reflecting the tissues at all, the guidelines that we are going to be following is with respect to the soft tissues or our buccal emergence profile that we want. Like if I want my emergence buccally at this very point, my implant should be at least at a 4 mm depth from the buccal soft tissues. That is the minimum depth that we are talking about, right? In any of the posterior anterior cases, whatever we are doing, the minimum depth of placement of an immediate implant has to be 4 mm apical to the soft tissue emergence part from the buccal emergence of the implant. So, as I said, if you are considering this part of the buccal gingiva as the reference, because that is where our buccal emergence of the tooth is going to be, my implant is going to be 4 mm apical to it, right? And once I know how deep it is going to be, I should even know the buccolingual or buccopalatal placement. So every implant should have some jumping distance from the buccal plate. It cannot be in contact with the buccal plate. Okay. This jumping distance is supposed to be at least 2 mm. If it is more, I don't see it causing any problem. So there is something called as 3:2 rule, where it says 3 mm deep, 2 mm jumping distance. But for immediate, I feel it is 4 mm deep at least. It can be deeper, it's not an issue, but it has to be minimum 4 mm deep. And there has to be some jumping distance from the platform of implant to the buccal bone so that area stays the stable. When the implant comes directly in contact with buccal bone, it is going to start resorbing. So we cannot use very, very large implants, especially in the anterior cases. They need to be avoided. We need to use smaller implants, especially in anterior cases, right? Okay, just a few minutes back, I actually added this picture because I realized I did not have any anterior photos for implant placement. But again, here, what you'll notice is a lot of jumping distance from the buccal aspect. Okay, so the implant has been placed at a sufficient depth, uh, and it has been placed at a sufficient palatal distance also, and which gives good enough thickness of the soft tissue overall, right? Uh, So whenever I'm planning any immediate implant case, this is how I actually start. Okay. So I see clinically where is the gingiva present. I mark it some. So you can probably see a shadow either in CVCT of the soft tissue, or you can roughly take it based on your clinical scenario. Like in this case, the tooth was almost at the gingival level. So I mark 4 mm from there, and that would be my position for placement of implant. So this is how I on CBCT find out, okay, this is probably the position, and that is how I would come up with the size of my implant. If I'm placing an implant, okay, now this is the size which I'm looking at for the implant placement. One very, very important factor for deciding whether you can go with the immediate implant or no is how are we going to develop the primary stability, because that is the main concern. That is one difference between delayed and immediate implant, that how do we make our implant stable. If we are extracting the tooth, there has to be some amount of bone present apical to the root so that we can place immediate implant. What is the value that you are looking for? It is 3 to 5 mm of excess of apical bone beyond the root that we need so that our implants can be stable. Okay. So most of the cases where you find such abundant bone, they are like the excellent cases that where we can go ahead with immediate implant placement. Okay. Again, if I'm planning it for this molar, what do I do is I start from my soft tissue point. I go 4 millimeters more apical, and then I plan my implant size. Okay, this would be the probable implant size that I would be choosing in the immediate implant case. And again, as you can see, this exact point, center of the implant is where my root apex is almost coming, and at least 3 to 5 millimeters of my implant is going to be in the alveolar bone, which is going to provide great amount of stability, and even there is a great safety margin from the inferior alveolar nerve. So such cases are wonderful to go ahead with immediate implant cases placement. What about premolars in the areas where we do not have the apical bone? So what do I do? Again, I always start with my 4 millimeter planning. So this is where my soft tissue margin is intraorally. I went 4 millimeters apical to it, and this is all the bone that I'm left with. Okay. So if I'm planning the implant of XYZ size over here, there is absolutely no bone apical to the implant left. So how do I gain stability? The only area where I can gain stability is mesiodistally. Is my implant wide enough to engage the mesiodistal bone and still be stable? That is the question. So what do we do is we go to other sections and we see how is the anatomy of the root, and are the root of the adjacent teeth far enough that allows me the placement for the placement of implant in premolar sites or even anteriors or wherever where I do not have sufficient bone apical to the area where I'm supposed to place the implant. If the answer is yes, we should always attempt for immediate implant. If we do not probably achieve stability, you can uh, just let it be and go ahead with your delayed implant placement. But always an attempt should be made in such cases. With experience, probably will start understanding that in what cases we can and we cannot go ahead. Okay. The third consideration is grafting. Do we have to do grafting or do we not have to do grafting? Most of the reports say that if we have good enough buccal bone and if the biotype is thick, we can avoid grafting. But there are multiple researches which support that whenever the bone grafting has been done, it improves the overall contour and stability. So the main reason we are performing immediate implant over delayed implant was to preserve what was there while we are extracting, right? So the if the main purpose of the entire treatment is preservation, I think grafting becomes a must, because without grafting we start losing a lot of it, right? So hard tissue grafting, bone grafting is almost compulsory. We cover it up with some kind of custom abutment after the graft has been placed. And soft tissue grafting, mostly it is recommended in anterior cases. A lot of research says that you can make it like a generalized rule. You can do it in almost every single anterior cases. It's always going to be beneficial and make the treatment more predictable. Or it is at least required in the patients with thin biotype. Whenever you are placing a probe in gingival margin and you can see through, you can see the probe, you need to do grafting. If you think the biotype is thick enough, you can probably avoid soft tissue grafting. Okay. Soft tissue grafting might not be required in posterior sites. We can avoid it in most of the cases, but it is going to be required in especially the aesthetic sites, which is maxillary 3 to 3, 4 to 4, whatever site you consider, right? So what we have covered till now is the biologic consideration, which started with atraumatic extraction. Once the tooth is extracted, the next very important thing to do is socket curettage. Okay, you need to spend 10-15 minutes of your time just cleaning out all the soft tissue which is present, which is seen, for which you will require very, very fine curettes, small headed curettes. Again, magnification is going to be very helpful so that after 10-15 minutes of curettage, you realize that all that you are scraping and you are in contact with is bone, and there is no soft tissue left in the socket, because Whatever soft tissue is left, that is going to endanger the final outcome of the implants, right? Implant positioning is very important because that is going to determine how stable the implant is going to be and what the final outcome will be. Okay, at proper depth, when I say depth, it's going to be more than 4 millimeters, jumping distance of at least 2 millimeters. Bone grafting in every single case. What material to be used, we can discuss with the as the slides follow. And soft tissue grafting is recommended in almost all the maxillary anterior cases. Okay. Now coming to the other important aspect of the immediate implant, which is implants itself. What kind of implant do we use? Okay. So I personally am a big fan of a of the tissue level implants. Okay. Especially for the posterior implant placement. Every single implant, premolar and molar, always consider, can I go for a tissue level implant? And there is another option of bone level implant. So what exactly do we go ahead and what are we looking for whenever we are doing immediate implant? Let us go through each one of them, understand what is the difference and what are the qualities in implant that we are looking for whenever we are selecting an implant for a immediate implant case. So firstly, for the people who are not very sure what the tissue level implant is, the rough surface of the implant always goes in the bone, and the polished margin, if we have this vertical polished collar, it's a tissue level implant. There are few companies which come with a very short collar with a excuse that anyway we are going to lose some marginal bone, so let's have this polished collar available so that it's easy to clean if in case the part of implant gets exposed. It is it is actually a bone level implant, but with a vertical polished collar. Doesn't make a lot of sense, but yes, it is an intermediate type of implant. And the implants which do not have any vertical polished collar, they all come under bone level implants. Fine. So starting off with the tissue level implants. So my all my initial cases, I used to try to place uh, tissue level implants even in immediate implant cases. Like this is one of the premolars which I had extracted and attempted for immediate implant. I used to open up the flaps, so that's one of the mistake again which I used to do initially. I created the osteotomy at the required site. I had around 3 millimeters or 2 millimeters bone available, but still I had to do a sinus lift along with immediate implant placement. So this is the sinus floor, the Schneiderian membrane, which you can see. I've grafted the site. I've did a hydraulic sinus lift, indirect sinus lift along with it. And as you can see in the IOP, a lot of graft has been placed, and I've placed a tissue level implant in this. I let the implant heal over a period of time, and this is almost 1 year after the prosthesis was delivered. The implant is stable. We have good consolidation of graft, and patient is almost fine. This can be considered as a successful outcome if your criteria are such. But again, if you see, we have lost some amount of marginal bone over here. And with more understanding of implants, I have realized that tissue level implants, whenever they are placed subcrestally, are always going to induce some amount of bone loss. Okay. Since all immediate implants are going to be placed in a condition which can be called as subcrestal, any polished part of titanium should not go below it. So most my personal recommendation would be to never go with a tissue level implant whenever we are going ahead with a immediate implant placement. Again, so there's a noble replace implant. It comes with a very fine 0.5 mm, I think, vertical polished collar. It also has the same problem which tissue level implant has. Whenever it is placed subcrestally, it induces some amount of bone loss. There is no bone attachment to the polished part. Soft tissue will come and attach to this part. So there is no point placing them subcrestally. So two of these implants are out of the question. What we are left with is array of different bone level implants. Okay. They also come in different shapes, sizes, and everything. And Few of them you see there is absolutely no polished component. This is a Straumann BLX implant, a beautiful implant. This one is any ridge implant. They come with a horizontal polished collar. So what is the difference in all of them? Let's try to understand one. I've just put a lot of implants over here so that we can understand what is different in them and what are we exactly looking for when we are selecting any implant company. So now I'm not promoting one over the other, but let's practically see which one is more indicated and what makes our life easier. Okay. Some clinicians are so experienced and well versed with one particular system that they may be able to achieve primary stability using any of these implant system. Okay. And if you are one of them, it's fine. You can go ahead and place any bone level implant wherever you can gain primary stability. But wherever uh, a slightly inexperienced dentist or a newer dentist is starting off, we should always look for few of the features which I'll be pointing out, which makes our life easier whenever we are placing immediate implant. So first implant, which you can see on the left side, is a ankylose implant by Dentsply. Okay. I was actually introduced to this system by Dr. Georgios Romanos in one of his lectures. In immediate loading implants, they have beautiful outcome and beautiful marginal bone stability. But whenever we are doing immediate implant, what we are looking for is the thread of the implants. They need to be slightly more engaging. If you look over here, the coronal half of the implant do not have adequate thread depth, which is going to make implant a bit more difficult to achieve the primary stability whenever it is inserted. Secondly, it has a cylindrical shape. Okay. If the implant is not tapered enough, the osteotomy has to be at least to the diameter of the apical part of the implant. If we are making such wide osteotomy, gaining the primary stability would again be a bit more of a challenge in such a case. That is why it is not very recommended to use a cylindrical type of implant. So the second implant that we are looking at is a tapered implant. This is a noble replace implant. Anatomy is something which is very much desirable. But again, the problem with this kind of noble replace implant is they have very passive threads. The depth is not enough so that we can engage good enough amount of bone to achieve primary stability. So again, anyway, noble replace is recommended for delayed implant, but I'm just discussing the type of implant. The third is a biohorizon or a camlog implant, a through and through tapered implant, perfect anatomy for immediate implant placement. It even has the apical cutback. Okay, what is this apical cutback? Main purpose is whenever you are screwing in the implant in position, this area can cut bone wherever the osteotomy has not been done. Okay, or if you want to place it further deeper than where you have done the osteotomy, this cutback is going to help you and cut slightly more bone, and that is why you will achieve more amount of stability. It is a very good anatomy for placing an implant, but probably not the only factor that we are going to be considering in the implants. But as far as the implant shape, the thread shape, everything is concerned, it's a beautiful shape for selecting as a immediate implant placement. The next two implants are the Hyoscine and the Straumann BLT implants, the bone level tapered implants. So again, the taper of the Hyoscine, this particular implant is not good enough. Even if you see the Straumann BLT implants are almost conical till the middle half, and the only the apical third is one which tapers. What we want is a complete taper, like one in the camlog implant or the next two implants. Okay. So these two also might give us some amount of difficulty in achieving primary stability. The thread depth is not enough. Again, they are slightly aggressive because they have a huge cutback seen. There is dual cutback in this Hyoscine implant. There is a cutback over here, all the way going to the middle of the implant. Now, Straumann has a better implant called as BLX, which was there in the previous slide. Okay, which has all the features that are important for a immediate implant placement. It's been recently launched, I think, in 2019, but for many years they were promoting this BLT implants, which makes it difficult for newer clinicians to gain good enough stability in any immediate implant case. The last two implants are the Noble Replace and Megagen Any-Reg implant. Okay, so what we see over here is a implant with a complete taper right from the crestal part all the way to the apical end. Okay, so such a conical anatomy is the most desired anatomy. Secondly is the thread depth. Okay, deeper the thread, the better is going to be the engagement with the bone, more is going to be the primary stability. There are limits to it, how much it should be, how much it can be. I'm not going a lot into the theory because probably the implant company are doing good enough job in finding what should be the right balance. Fine. And we have a huge cutback over here in the apical part of Noble Active, which makes it a very aggressive implant. Such a feature is not there in Megagen, which keeps the implant active but doesn't make it aggressive. So there is a slight difference in the two. Both of them are active implants, but the Noble Active is rather more aggressive. It is like a osteotomy drill. It acts like a drill. If you push it in, it just rotates, cuts the bone, and it might even be able to go in the other direction where the osteotomy was not done. And if you keep rotating, it will keep going and pushing and creating its own way. So the advantage can even become the disadvantage in few cases. Whereas Megagen implants are kind of active. They wherever the osteotomy is done, they retain the position, and because of the thread, they're able to maintain excellent amount of stability. So such is the anatomy that we are looking at for any implants, right? So what we realize till now is what we want is a tapered implant with good thread depth and the conical shape, right? Besides that, what we are looking for is the platform switching. Whenever we are going for a subcrestal implant placement, what we want is a platform switch implant. Unless there is platform switch, we are always going to have some amount of bone loss around the margins. Secondly, what we are looking at is the abutment to implant connection, right? So the conus over here is at around 45. The point at which the implant and abutment touch each other is at a 45-degree angle, which makes it slightly unsuitable whenever we are placing them subcrestally. Okay, I am not saying one kind of connection is superior to the other, but in the scenario that we are going to be using it, the subcrestal placement, these 45-degree corners do not achieve the ideal result that we want. Okay, this Noble implant used to come in two type of connections. One was this 90-degree butt joint, and one was the tapered connection. I think this one, the trilobe implant, have been discontinued, so we don't have it anymore. But again, such kind of joint, 90-degree joint from implant to abutment, are not very stable. The very stable connections are these conical connections where the abutment actually goes inside, and this connection is less than 20 or less than 20 degrees. Okay, the previous one which we saw over here was almost a 45-degree connection. There are a lot of implant companies which come with this 45-degree connections. We don't really want them to use subcrestally. What we are looking for is this conus connection, or even more ideal would be to have these more tapers, like a 5-degree connection with Megagen and Neeraj. What happens is as we tighten the abutment, there is a cold welding which is going to happen between the abutment and the implant body. What it does is it achieves excellent amount of stability of the abutment, and since there is no micro movement of the abutment under function, the connection stays very stable, and the bone which is formed around the implant also stays very stable, right? So these are the few things that we are looking as far as the implants are considered. Always go for a bone level implant. It should have absolutely no vertical polished collar or neck. We want tapered body right from the coronal to the apical aspect, not like just the apical tapered part. We should have active threads, and it should have horizontal platform switching. The implant to abutment connection has to be more taper, which is 20 degrees or lesser. We don't want those wide 45-degree connection or 90-degree corners, right? We want more steeper 6 degree, 8 degree, 10 degree, 20 degree, such connections. Now, just going through few of the cases, again, a couple of them I already showed you before, but let's go through those cases slightly more in detail so that I can discuss each of the step and we can understand how the immediate implant was done. So while planning this case, this is about the 3/6 implant over here. What we have is around 7 of bone apical to the root on the distal side and around 5 bone apical to the mesial root. So I do have good enough bone present around apical to the root, and that is why it's a good case to go ahead with the immediate implant, right? Again, for selecting the size of the implant, I choose to go 4 millimeters deeper from the most coronal part of the soft tissue and see the implant size. I've already shown how we section the molars into two roots, remove one at a time, and what we are left with is a very, very good soft tissue envelope which is present all around, and the two root which are empty. Now, there is a very good classification which is given for how the sockets are, especially for the posterior side. So I'll just quickly go through them. So there is something called as ABC classification, where if we have a lot of bone present, it comes under type A. Like type A socket would be where we are placing implant, where the most coronal part of the implant will be 100% in the bone. Okay, the entire coronal aspect, it is as good as having a delayed implant. It is completely in the bone. There are few cases where part of it is going to be in the bone and part of it is going to be not surrounded by the bone. Okay, those are the cases we call as type B socket, and there are sockets where the furcation bone is absolutely missing, like a single conical root might be present for a second molar or something like that. And the entire stability we get is from the surrounding walls, buccal, mesiodistal wall, and such are the type C socket. Okay. As you can see over here, the maxillary molar, we have so much of the furcation bone that the entire implant, the most coronal part was in the bone. So this is a type A socket. Type B, again, a part of the implant was outside the bony wall and part of it has support of the bone. So this becomes a type B, and type C would be, as I said, completely in the socket. There's not enough furcation bone, or it is so thin that we choose to remove it. We choose to remove the furcation bone and we just engage the entire walls and gain the stability for the implant. Okay. So there are different kind of implants that we use for such kind of type C sockets. They are the wide types of implant. They are only used in type C sockets for posterior implants. Okay, these are the wide implants that we are going to use only for type C posterior implants. Okay. Anyway, coming back to our case. So what we have here is a type B socket. Okay, we have some amount of furcation bone which is going to gain us the stability. I'm not removing all of it. So we'll be placing an implant at a 4 millimeter depth. As you can see, actually it's slightly more. It's around 5 millimeters, 2 millimeters of soft tissue, around 3 millimeters from the bone over here. Okay. So it is almost at that depth from the lingual aspect of the gingiva. From buccal is going to be slightly lesser because the lingual architecture is almost always slightly more coronal to the buccal side. Okay. So we might be around 4 more apical from the buccal part of the bone. Next thing that we do is we graft the entire site. How do we graft? So we need to take care the implant is closed either with a cover screw or with a small healing abutment while we are grafting the site so that nothing goes inside the implant. Otherwise, it's going to become very difficult for us to retrieve those graft particles. What graft material is ideal? Okay, what should be placed? So either we can go for a xenograft or we can go for allograft. Either of them are good choices, but xenograft generally ends up taking more time to turn over. Okay, it stays for a very long time, and what we want is good viable bone to quickly form around the bone. So maybe allograft might be a better option. In this case, I have anyway used a xenograft. And finally, we cover it with something called as custom healing abutment. Okay. How do I fabricate it? I'll be explaining in the next case. Okay. So this entire part of the socket opening should be covered with a custom healing abutment. Now the question is, can we not just place a healing abutment and close the gingiva, or just close the gingiva by releasing it a little? The Again, going back to our initial point, like the entire point of having the immediate implant is to preserve the anatomy. If something does not help me achieve the goal of preserving the anatomy, I won't be doing it. So if I'm placing a wide healing abutment, there is still a part of tissue which is going to pull back or collapse, and it's not going to be completely supported. The only way to completely support the soft tissue around the implant would be to recreate the same emergence that the tooth originally had. And that is why we would always want to go with fabrication of a custom healing abutment. That is what I do for every single case of mine. Okay. And this is where we reach initially by creating a custom healing abutment over a temporary abutment and grafting the site, placing implant in the deep enough position and parallel to the both the teeth, right? We wait for few months and this is what I achieved. Okay, the patient had come back in probably say 5 months. There was some food lodgement actually below the custom healing abutment that I had made over here. And since there was no follow-up for multiple months, there was some ingrowth of soft tissue. And as you can see, I've lost some amount of hard tissue, but still a beautiful anatomy could be maintained all around over here. And what we have over here is, from what I can see over here, is the free gingival margin. Okay, the first layer that we can see over here is the gingiva, the epithelium. Okay, inside of which is the junctional epithelium, which is going to be in contact with the final prosthesis that we create. And the third deeper part of the tissue, which is present just around the neck of the implant, is the connective tissue. Okay, so there are three layers to the biologic part around the implant, which are going to be present around the prosthesis. Why am I telling you is because the prosthesis should also be conducive to maintain these anatomic structures in the position that they are. Okay, again, going through them, the most coronal and the most outwardly part of it is the pregingival margin or the epithelium. Okay, inside of it is the junctional epithelium, and the most closest part to the implant would be the connective tissue. And there might be some graft material which are either embedded in the soft tissue over here, or few of them actually might just not be very much inside the soft tissue. So what you can do is you can just remove whatever particle are loose or mobile. Whatever is inside the soft tissue, you can just leave it. So what is the function of having the graft material in the soft tissue? Is it good? Is it bad? The thing is, it is kind of good because it increases the firmness of gingiva. So this photo has been taken after a long time after removal of the custom healing abutment. What we generally see with implant soft tissues, they collapse as soon as the healing abutment is removed. But that doesn't happen in the case of immediate implant. The anatomy doesn't collapse. It's very easy to take impression or make impression around this area because the entire site is much more supported by the graft particles which are embedded in the soft tissue. Whatever is almost free can be removed. Whatever is very well embedded should be left behind. Okay. So there are these parts. First one is the titanium abutment of the prosthesis. Okay. We are always the most stable prosthesis that we can give is a zirconia crown around the soft tissue, around the immediate implant. So what is going to come in contact with the connective tissue is our tie base. Okay. This tunnel area which we had created by giving a temporary abutment, now that is going to be replaced by the tie base part of the implant. Okay. There is a way of selecting tie bases. Probably we'll see in some time, or we might skip it. The most important part is this entire junctional epithelium part. Okay, that has to be in contact with the zirconia part of the prosthesis. Okay, the zirconia prosthesis has to be unglazed. It has just to be polished, because the polished zirconia is the only material where the junctional epithelium actually attaches itself. Okay, there is a physical contact between the polished zirconia and the epithelial cells, and that is what maintains the anatomy or even improves the anatomy over a period of time. Okay, and finally, what we have outside in the mouth, what we see is the glazed part of the zirconia crown, or whatever prosthesis that we are giving over the zirconia abutment, right? Most of the labs might not give us this unglazed part, or they might just glaze the entire crown. So there are these twist drills which are available, and you can remove all the glaze from the integral surface of the prosthesis, the part of the prosthesis which is going to come in contact with the soft tissue. Just use these drills and spirals, and you can remove the glaze. And what you can do is just expose the zirconia which is underneath, polish it well, and a well polished prosthesis would be the best to be in contact with the junctional epithelium. And finally, what we want is slight amount of pressure on the soft tissue, which will maintain and support the soft tissue contour. As you can see, this is the mucogingial junction, and we have very, very nice width of keratinized tissue, which was maintained, beautiful soft tissue papillas, which are maintained in that area, a very good emergence that we could achieve in this case, and very good maintenance of the bone around the implant also, right? Again, very similar case which we had initially shown. A premolar, we section it, divide it. What I'm doing over here on the other photo is curating the socket. That is to be done in every single case. We remove all the soft tissues which are present inside. We start drilling in the position that we want. We place the implant. We go to the desired depth, okay? That is 4 millimeters below, and then we are placing a temporary healing abutment. Temporary abutment is what we use to make the custom healing abutment. Okay, so I've placed the custom abutment, and I've reduced the height to whatever I want. I've grafted the site with bone particles, and there's just a small video as to how I make the custom healing abutment. Okay, so what I've done is I've placed the custom abutment over the implant that was placed. I've layered it with one layer of flowable composite. And now what I'm doing is I'm just putting some amount of composite over it, and I'm curing it immediately. What I want to do is record the entire soft tissue emergence which is present, and it can be created very easily in the intraoral scenario by using this flowable composite and directly curing it inside. Once that is done, I will take out the entire prosthesis. I'll fix it with a lab analog and then create the apical emergence of the custom healing abutment. This is just to record the coronal part as to how it's supposed to be closing the socket area, the most coronal aspect of the custom healing abutment. There is another process in which we recreate the apical part. Okay. Okay. Anyway, I'll just continue. So what we do is then we remove this custom healing abutment, we fix it with the lab analog. Then I add the flowable composite on this apical part, and then I create the contour. Okay, this has to be concave in shape. We do not want convex. Okay, these all shapes are to be concave. They might look very exaggerated, but that is how the jumping distance is, right? We keep a lot of distance from the buccal bone. We keep this buccal area. We try to keep all the under surfaces of this custom healing abutment concave as much as possible. And all we have to do is just screw it in and close this top part with a flowable composite, right? I just do a small marking so I I have the guidance for what is the buccal side while I'm polishing it, so I don't end up changing the shape of the prosthesis, right? And this is how we get our final implant in the position. As you can see, it is sufficiently deeply placed implant, right? And quickly just showing a case of anteriors, which we probably do much more often whenever the immediate implants are to be placed. We extract the teeth. I ended up damaging a few of the papillas over here. Then we place the implant in desired depth. Once the implants are placed with some jumping distance from all the side, what we do is we graft the entire site. Immediately that time I made this entire uh, temporary for the anteriors with three custom abutments, sorry, temporary abutments. I have made this entire temporary prosthesis for the patient. And then finally, after 3 months of healing, I have placed the final bridge for the patient, right? It's a zirconia bridge, same. The the all the tissue, all the part of the bridge that were in contact with the tissues were polished and unglazed zirconia, right? Probably the distance should have been a bit more between these two implants, but okay, even I'm learning with time. And a lot of my understanding of the immediate implants actually come from this one particular educator, which is Thomas Linkevicius, and I greatly recommend attending his lectures and courses if you can. And I think that would be it. And it would be a good time to probably have some questions if anyone wants, right? So anyone can go ahead if there are any questions we can discuss, we can ask, right? Tell me.
Doctor, can I read it?
Okay, let me read it actually. So over here. Mm, So which instrument do you recommend for atraumatic extraction for posteriors? So as I said, I just have very limited instruments. Okay, what I have with me is the Ufredi periotome. Okay, that I always use to dissect the tissues around it. Dissect as in just put it through the gingival sulcus all around so that I can uh, take the tissues away from the teeth. And then I start using all my luxators. The luxator which I use are from Directa company. They are very fine, very sharp. They actually start going in the PDL space around the root. And in most of my cases, I do root sectioning. I do not remove anything in total. I dissect from buccal to palatal whenever possible and not from mesial to distal unless the tooth demands it. Like first premolar, I cannot have a buccal and buccal to lingual because there are two roots. One is buccal, and that is why I have to section it mesiodistally and then remove one at a time. Okay. And yeah, that is it. So it's periotome, luxators, and sectioning instruments, whatever you need. There are Zikria burrs which are available to be attached with the handpiece. They are the long shank tapered burrs and they are used for sectioning of the roots. Most of the times, if the crown structure is present, I first do the decoronation. I remove the crown so it becomes easier to section the tooth. Maxillary molars are sectioned into three roots, so it's trifurcation. Okay, it's trifurcating the roots. Crown cell extraction, custom healing abutment. How do you fabricate? I think I already answered how do I fabricate the custom healing abutment. Sir, we don't have to cover the bone graft with the membrane. Okay, so the main purpose of membrane no, is generally to protect and stabilize the graft and to prevent the ingress of epithelial tissue. What are the membrane called as? Barrier membranes. Okay, the name of membrane itself is a barrier membrane. So what does it do? It prevents the soft tissue from growing into the hard tissue. Whenever we are doing immediate implant, what is going to happen is most of the grafting is going to be in the socket itself. and socket whenever it's left even without grafting, bone is anyway going to grow. Whatever grafting is done above the platform of implant in the 4 millimeters that we have placed the implant subcrestally, we don't really mind some amount of soft tissue growth because there is going to be soft tissue collar which is going to be forming around the implant. So that is why we don't need any membrane. Plus, stabilization and preventing any contamination of graft is anyway going to happen with the custom healing abutment. So we don't even have to think about using a membrane separately under the custom healing abutment. Okay. How to choose the tie base? Ginger height, choose lower. Okay, so how do we choose the height of the tie base? So it actually depends on how much amount of bone is left or regenerated. Okay, so sometimes what happens is, if you can see the video which I'm showing, so once we have placed the implant and we have placed a custom healing abutment over it, okay, what happens a lot of time is we have this entire grafted site as regenerated bone. So if we have more amount of bone present coronal to the implant platform, we need to use higher tie base because we cannot crush the regenerated bone. But sometimes in the case which I had shown, let me show it to you once again. Mm, Over here, a lot of regenerated bone has actually been reduced. And what we have right now is, what do I have in this case is the bone has almost reached to the implant platform level. Okay. So in such case, it doesn't make sense to have a very high tie base. Okay. So using a lower tie base would mean that I would have more amount of zirconia in contact with the soft tissue. The and my first thing that should be in our mind is, how do I enhance the zirconia to soft tissue contact? That is by using lower tie base. So in this case, it is possible since I don't have a lot of bone above the implant which is regenerated. Okay. If there are cases where I have a lot of bone present vertically around the implant, then I would be using a higher tie base, okay, rather than a low tie base. What impression material that you use and techniques do you prefer? Scanning. As I said, the soft tissue. So the question is, what impression material or technique do you use, and do you prefer scanning over impression materials? So since the soft tissue doesn't really collapse whenever you're doing immediate implant, it doesn't matter if you're using a scanner or if you're using a standard impression material like adhesion silicone. I do it either way, and there are techniques to scan the custom healing abutment and to send them the emergence profile, and there are ways to recreate that with the impression material too. Okay, you can use both. A lot of my cases I just scan directly. I scan the soft tissue, I scan my scan bodies, and I directly send it to the lab. They do fabulous job in recreating the anatomy directly with that, so I don't have to do anything additional. I use Duo implant. I feel they are passive. Are Norris implants better option than Duo? I thought they are Israel system. So I'm not very sure about Norris and Duo, both the implants, because I haven't used them. But uh, i- first thing that you need to check with any Israel system is what is the implant to abutment connection. A lot of them have a 45-degree conus. Like I have used Aiden implants, they have the 45-degree connection. They are not to be used subcrestally. So if Norris is similar to that, if they have a 45-degree implant to abutment connection, they are not the implant of choice. Even though the threads might be very aggressive, threads might be very, very active, but if the implant abutment connection is not right, we don't use it. Can we use PRF instead of bone? Probably we can use, I don't know, I haven't used it. I haven't read a lot of studies about it. So, and uh, I've not come across a lot of people talking about it, but why not? Probably you can try. PRF will help in soft tissue healing. It will help in hard tissue healing. What we are looking over here is to create more stable soft tissue around the implant. and bone grafting might have some superior result in my thinking. But again, biology doesn't work as what might feel more intuitive to me. So again, someone has to do studies, or maybe they just need to check it by themselves, do 5-10 cases, see if it really works. Do you need to apply a layer of bonding agent before using flowable composite? No, custom healing abutments have the margins which are very serrated. They are rough. Composite do stick very well to it, so we don't need to use any bond. Which loops do you use in your practice for root sectioning? I have Carl Zeiss loops. They are 4x, the maximum magnification, which I generally use. And once I finish with the sectioning and removal of the roots, I generally end up finishing the use of the loops. Then I do not use it for my implant procedures. I mostly do it with our normal eyes without any magnification. It's just for the sectioning, or if I'm doing any socket shield technique, that is when I use the loops. Otherwise, I don't. Are there any more questions? Or else I think we are done today.
Doctor. Thank you, Doctor. I think
Thank
we'll
you very
wind up.
much. Yes.
Once again, thank you so much for sharing your knowledge and expertise when it comes towards managing this session. Surely many of us would leave this discussion with amazing takeaway points and implement techniques as we discussed.
Hmm.
Thanks to all doctors for patient listening and your participation for this webinar. And I hope all of you will depart this session with positive, confident manner. Please do
Thank
check
you.
follow doctor's Instagram page where you can appreciate his clinical works. And to know more about our upcoming webinars and workshops, please do check out our website, which is iadpe.org, or you can follow our Instagram and Facebook pages as well. And if you have missed our previous webinars, do check out YouTube channel as well. And we really appreciate if you could subscribe as well. So thank you all and have a great night.
Thank you.
Thank you, Doctor.
Please, how do I leave the chat?